Good afternoon, ladies and gentlemen. So I think you, or some of you may have seen the live case from Professor Sievert yesterday. I think it was yesterday. And unfortunately, our case was also planned for a live presentation, but unfortunately, it was very hard to explain to the patient to wait for another 3 weeks because he was in a pretty poor condition, and so we immediately had to perform the procedure. So this is my disclosure statement, and just a quick summary of the patient's history. So he's basically an 88-year-old gentleman with severe tricuspid regurgitation, of course, and I would call him a kind of a frequent flyer. This is the word we are using in our hospital for those patients who frequently come because of cardiac decompensation. His past medical history includes long-standing atrial fibrillation. He had undergone an M-tier procedure with only mild residual MR in March 2025. And on the other hand, he had preserved LV and RV function with significant enlargement of his right heart chambers. He had no pulmonary hypertension, and he had started to develop renal failure, probably due to renal tamponade as a consequence of increasing central venous pressures. So I don't need to explain this. There is just one important thing which I want to emphasize. So this is his echocardiogram 1 day before the procedure, after he had undergone an intense treatment with IV loop diuretics. And he was screened for several devices, but unfortunately he was turned down for edge-to-edge repair, for the direct annuloplasty, for valve replacement, of course, and also for heterotopic valve replacement. So there is an alternative treatment option, at least when you look at the literature. There is no CE certified device on the market yet. Most of you will be familiar with the former device, which was available, I think, 5 or 10 years ago. This device was withdrawn from the market because it was related to RV perforation due to the anchoring mechanism, and it was not very effective in terms of TR reduction due to the problems to maintain the center line. There is now an alternative treatment option with kind of the same strategy, just with a little bit of difference that the balloon is not coming in a 90-degree angle. It's implanted from the IVC, so from the femoral vein basically, and crosses the tricuspid valve in a horizontal manner, and therefore covers both the anteroseptal and also the posteroseptal commissure. So in theory, the advantage of this device is basically an all-comer device, so you could use it for all kinds of tricuspid pathologies, even for degeneratives one, and the typical limitations as coaptation gap, anatomical problems, imaging problems, large annuli, poor RV function shouldn't be as obvious with this device compared to the usually used implants. So this is a summary of the procedure. It's basically started like a right heart catheterization. So you can see we are trying to maneuver the catheter into the pulmonary artery. We are using a steerable sheet here, so an Achilles sheet, because as mentioned before, the tricuspid or the right heart dimensions, they were very dilated. Then the next thing is to move a wire or a catheter into the right pulmonary artery, and the most important thing is that you avoid entanglement of the wire in the subvalvular structures, which you can see here. We usually also use 3D echocardiography to prove that, so it's very similar what we do during the EVOKE procedures or during a pulmonary valve implantation. Similar to pulmonary valve implantation is also the equipment you use. So usually we are using a very stiff wire And this is a description of the device. That's also the second generation device, so an implant which is considered to stay as a permanent implant. You can see the spacer balloon, the distal anchor, and it's all mounted on a kind of sheet, is then loaded onto the sheet, and once it's crimped on the sheet, then it's advanced into the body, and it's brought into the pulmonary artery position. So, as mentioned before, this is just very similar to other procedures. And I will try to shorten this a little bit. So now we have brought the device into the pulmonary artery. Then the balloon is resheeted by withdrawing the sheet. And then the next step is to inflate the balloon. And you can see the spacer device on echocardiography. You can choose a little bit the diameter to which you can inflate the balloon. There are also several devices available, or several sizes of the device available. And finally, the implant is detached from the catheter, and the spiral anchor attaches to the IVC, and the device is locked. So that's the final result. That's pretty impressive in my opinion, but you all know you can do a lot with color Doppler imaging. So I show you an additional slide. That's the hemodynamic consequences following the procedure. You can, or as I mentioned before, the patient had a MitraClip procedure, and therefore he had an interatrial shunt. And you can see before the procedure, he had a bidirectional shunting, and after device implantation, there was only left to right shunt left, and also his left ventricular stroke volume increased by about 20 to 30%. So a little bit about his peri-procedural blood work. So creatinine levels went down from 1.6 the day before the procedure to 1.2 on day 3. This was the day when he was discharged. And this is thank you very much. That's my summary. I think I have mentioned everything.
Okay, thank you very much. I think, Markus.